Ever felt like you need a translator just to understand healthcare? Maybe wrestling with what happens after a hospital stay.
Oh, definitely. Or even just looking around your community and wondering, why are things so different health-wise from one neighborhood to the next?
Exactly. That feeling of uh, being a bit lost in the system or just plain confused by it all. If that sounds familiar, well, you're definitely not alone.
It's incredibly common, that feeling, whether you're the patient or just trying to grasp the health of the whole community. It's complex.
And that complexity is exactly what we're diving into today. We're focusing on population health and care transitions. We've got this really comprehensive guide that digs into both these areas and, importantly, how they connect.
Right. Think of this as getting the essentials.
Yeah, your roadmap, sort of,
Yeah.
to how healthcare is trying to get better at supporting individuals and building healthier communities overall.
Our goal here is pretty straightforward. We want you to walk away with a clear picture of what population health really is, what care transitions involve, why they're so critical now, and, what key strategies and maybe surprising innovations are making things better.
And we'll do it without drowning you in jargon, hopefully.
Exactly. Just the core stuff, the expert takeaways distilled down.
Okay, so our main source here is a certification course by Dr. Mazen M. Salama. He's a senior clinical data scientist, a quality consultant, also a practicing cardiologist.
Right, and founder of Thomasy and Datamia, both focused on using data for better healthcare quality. So he's really deep in this field.
Definitely credible.
Hmm.
We're also pulling from Population Health and Care Transitions, a comprehensive guide. Okay, so let's get started. Population health, care transitions. What are we actually talking about here?
Okay, so population health. Basically, it's looking beyond just one patient at a time. It's about the health outcomes of entire groups.
Groups like a town, a
Hmm.
specific patient group.
Could be anything defined: a city, employees of a company, people with diabetes in a certain region. The focus shifts heavily towards prevention, promoting healthier lifestyles.
And not just reacting to sickness.
Exactly. And crucially, collaboration. Getting healthcare providers talking and working with, say, schools, public health departments, community groups. It's much broader.
Right, a proactive sort of community-wide effort to keep people well. Okay, so then care transitions. That sounds more like the individual patient journey.
Precisely. Care transitions are all about the movement of patients. Coordinated movement, that's the key,
Yeah.
between different settings, maybe different levels of care.
Like hospital to home.
Hospital to home, yeah, or ICU to a regular room, hospital to rehab, even specialist back to primary care.
Okay.
And that word coordinated is vital. It's not just the move itself. It needs meticulous planning, really clear communication, smooth handoffs, so care doesn't get dropped.
Makes sense.
Yeah.
And I'm guessing these two things, population health and these care transitions, they're linked. They're not separate worlds.
Oh, absolutely linked, very intertwined. Think about it. If care transitions work well, patients do better. Fewer complications, fewer readmissions.
Which saves money too, I bet.
Huge cost savings.
Yeah.
But more importantly, it leads to better health for individuals. And when you have lots of individuals having better outcomes because transitions are smooth, well, that directly boosts the health of the whole population.
Ah, okay. So the individual experience during transitions ripples outwards to affect the bigger population health picture.
Exactly. Good transitions build trust, too. Makes people more likely to engage with the system effectively.
So let's dig into why these transitions are so critical. It sounds like more than just logistics.
Oh, much more. They're absolutely fundamental for patient safety and the quality of care. Get them wrong and the risks go way up.
And there's data on this, like actual numbers.
There is pretty stark numbers, actually. A 2023 study, I think it was in the Joint Commission Journal on Quality and Patient Safety, found that poor transitions are linked to about 30% of hospital readmissions within 30 days.
30%? Wow.
Huh.
It's huge.
It is huge. It basically tells us there's a breakdown somewhere after discharge. The patient isn't fully set up for success at home or in the next care setting. And yeah, besides the human cost, the financial burden is massive. Billions of dollars every year in the U.S. alone.
So fixing transitions isn't just good for patients, it's good for the whole system's sustainability.
Absolutely. It hits both quality and cost.
And I guess some people feel the bumps in these transitions more than others.
You're spot on. Vulnerable populations, older adults, people with chronic conditions, complex medical needs, maybe social challenges too. For them, a smooth transition isn't just nice to have, it's essential.
Yeah, a small hiccup for one person could be a major crisis for someone else.
Precisely. Any gap in communication or coordination can have really serious consequences for these individuals.
Okay, so we know they're important. What kinds of transitions are we actually talking about? You mentioned a few.
Yeah, we can break them down a bit. One type happens within settings, so same hospital, but maybe moving from the ICU to a general ward. Different level of care, same building.
Okay, internal move. Makes sense.
Then you have transitions between settings. This is probably what most people think of. Hospital discharge to home health care, or to a skilled nursing facility, or maybe to an outpatient clinic.
Right, moving between different organizations or locations.
Exactly. New environment, often a whole new team involved. Then there are transitions across health
What
states.
does that mean?
That's a bigger shift in the goal of care, like moving from active, curative treatment for a disease towards palliative care or hospice. The focus changes fundamentally.
Ah, okay. That's a profound shift for the patient and family. And the last type.
The last one is between providers. This is when the main responsibility shifts. Maybe your primary care doctor refers you to a cardiologist, or the hospital doctor hands off care back to your regular GP after you leave.
Got it. Primary care to specialist or hospitalist to primary care.
Yep. And each of these types has its own unique friction points, things you need to watch out for.
Okay, so if we want these transitions to actually work, to be effective, what absolutely needs to be there? What are the key ingredients?
All right, several things are non-negotiable for a good transition. First up, a comprehensive care plan.
Okay, what's in that?
It's got to detail the patient's conditions, the treatment goals, what follow-up is needed. And critically, it has to be shared. Shared with all the providers involved, shared with the patient, shared with the family or caregivers. Everyone needs the same playbook.
Communication again. Seems central. What else?
You need a skilled receiving care team. The place or people taking over care have to be equipped for it. They need the right skills, the right equipment, the right resources for that specific patient.
So if you need, say, complex wound care at home, the home health agency actually needs nurses trained in that.
Exactly. Can't just assume they'll figure it out. Then there's logistical coordination.
The practical stuff.
Yeah, the nuts and bolts. Arranging transport if needed, making sure medical equipment like an oxygen tank or a hospital bed is delivered and set up before the patient arrives, getting prescriptions filled and ready. Sounds basic, but mess this up and it causes huge problems.
I can imagine showing up home and no oxygen.
hmm
Not good.
What about the patient and family?
Absolutely critical. Patient and family education. They need to understand what's happening, why the transition, what to expect next, and importantly, they need the knowledge and skills to manage things themselves, like knowing medication side effects or warning signs to watch for.
Empowering them.
Yes. And the final piece, tying it all together, is interdisciplinary collaboration,
Meaning?
meaning all the different professionals involved, doctors, nurses, pharmacists, social workers, therapists, everyone need to be talking to each other, sharing information, coordinating efforts, no silos.
So solid plan, skilled team ready, logistics sorted, informed patient, and everyone talking. That sounds like it should be standard, but maybe isn't always. That's often the challenge, making all those pieces work together seamlessly every time.
Okay, so what's changing? What are the sort of cutting-edge things or best practices helping to make this better? Any aha moments from recent research?
Yeah, there's some really encouraging stuff happening. Electronic health records, EHRs are a big one. When systems can actually talk to each other, interoperability, we see real improvements.
Like measurable improvements?
Definitely. Some studies, like one mentioned in Health Affairs recently, found something like a 15% reduction in readmissions in hospitals using interoperable EHRs.
15% is significant.
Yeah.
So just better information flow makes that much difference.
It really does. It means the receiving team isn't starting from scratch. They have the patient's history, allergies, meds right there. Reduces errors.
Okay, what else?
Standardized handoff protocols. Things like iPass. It's a structured way to communicate when handing off a patient.
Like a checklist for communication.
Sort of, yeah. Ensures key information isn't missed. And the data is compelling. A meta-analysis showed these protocols can cut communication errors by around 23%.
Wow. Structure really helps reduce mistakes.
It does. We're also seeing specific transitional care models making a big impact.
Models like,
Like the Care Transitions Intervention, or CTI, it often uses dedicated transition coaches.
what do they do?
They work closely with the patient before and after discharge, help them understand meds, make follow-up appointments, recognize warning signs. It's very hands-on. And evaluations show it works like a 20% drop in readmissions for heart failure patients in one recent study.
That personalized support during that vulnerable time Makes sense. It would help. Any tech beyond EHRs?
Telehealth, big time. Using remote monitoring or video visits for follow-up after discharge?
Checking in virtually.
Exactly. Reports show it's cutting readmissions, especially for chronic conditions like COPD. Maybe an 18% reduction seen in some cases. It lets clinicians catch problems early before they become serious enough for the patient to need to go back to the hospital.
So EHRs, standard handoffs, specific coaching models, telehealth, lots of positive developments. Now, the guide you mentioned outlines 7 specific intervention categories. Can we touch on those?
Sure, it's a useful framework.
Yeah.
Number 1 is medication management.
Always a big one.
Huge. Estimates suggest maybe 25% of readmissions are linked to medication issues, wrong drug, wrong dose, patient not taking it right.
So what else?
Key things are medication reconciliation, painstakingly comparing lists to get it right, giving patients clear, simple lists, lots of education, and using tech like barcode scanning or automated systems. Some studies show tech can cut errors by 30%. There are great examples like Kaiser Permanente's pharmacist-led programs cutting errors and readmissions significantly.
Right. Getting the meds straight is step 1. What's category 2?
Transition planning. We talked about the care plan, but this is broader. It involves assessing the patient's total needs, medical, social support at home, developing that detailed plan, collaborating across disciplines, and really involving the patient and family in the planning.
Not just planning for them, but with them.
Exactly, and structured planning works. One study showed a 22% readmission reduction for diabetes patients who had it. Models like the Transitional Care Model, TCM, really emphasize this upfront planning.
Okay. Meds, planning. What's number 3?
Patient and family engagement and education. This loops back to what we said earlier. When patients are active participants, outcomes are better. Research suggests engaged patients might have a 30% lower risk of adverse events.
How do you engage them effectively?
Shared decision-making, education that's tailored to them, using teachback, making sure it's culturally appropriate, and supporting the caregivers too. Tools like the Patient Activation Measure, PAM, show patients who feel more activated, more confident, actually have lower readmission rates.
Makes sense. Empowered patients do better. Number 4.
Information transfer. Again, communication. So many errors happen because information gets lost or miscommunicated during handoffs, maybe 35% of transition errors.
So how to fix that?
Better EHRs, especially using standards like FHIR so systems can talk. Structured handoffs like SBR. Clear roles on the care team. Patient portals so patients can see their own info. Studies, like one to the VA using standardized EHR handoffs, showed significant error reductions, around 28%.
Better info flow, fewer mistakes. Okay, number 5.
Follow-up care. That post-transition period is critical. Timely follow-up helps catch problems early.
So getting that first appointment scheduled quickly.
Yes, scheduling appointments promptly. Using telehealth for check-ins, as we mentioned. Care coordination to make sure nothing falls through the cracks. Patient reminders. Studies show timely follow-up significantly cuts readmissions, like an 18% reduction for heart failure patients in one study.
Closing the loop after discharge. What's number 6?
Healthcare provider engagement. The doctors, nurses, pharmacists. They need to be engaged in the process, too. It can't just be another task on the list.
How do you get that engagement?
Training on best practices for transitions. Promoting real team-based care. Giving providers feedback on how transitions are going. Maybe even incentives tied to good transition outcomes. Training programs, like using iPass, show that when providers are trained and engaged, errors go down.
So supporting the frontline staff. Okay, last one, number 7.
Shared accountability across providers and organizations. This is about getting everyone rowing in the same direction. When different providers or hospitals or clinics share responsibility for how that patient does after a transition, they're more likely to coordinate effectively.
How does that work in practice?
Things like accountable care organizations, ACOs, are built on this idea, using shared performance metrics for transitions, contracts that spell out responsibilities, building partnerships with community organizations. Models with shared accountability have shown impressive results, like 25% lower readmissions in some cases, and cost savings too, like in the Medicare Shared Savings Program.
So aligning incentives and responsibilities across the system. That's a powerful list of 7 areas. It really shows how multifaceted this is. Looking forward now, what's next? What's exciting on the horizon?
Well, AI is definitely a big one. Artificial intelligence and predictive analytics.
How would that work?
Imagine AI analyzing patient data to predict, with pretty high accuracy, who is most likely to struggle after discharge and be readmitted. Mayo Clinic had a pilot showing something like 85% accuracy.
Wow. So you could target those extra resources, like those transition coaches, to the patients who need the most.
Exactly. Proactive, targeted support. And alongside tech, there's that continued, maybe even growing emphasis on patient-centered approaches,
Meeting.
really doubling down on shared decision-making, ensuring care is culturally competent, tailoring everything to the individual's unique situation and preferences. The human touch remains vital.
Tech and touch working together. Okay, let's pivot now to the other big piece, population health. We defined it earlier, but maybe refresh us on the core idea.
Sure. So, population health, again, is that broader view, focusing on the health outcomes of groups, not just individual patients walking through the door. The main goal is improving the overall health and well-being for these defined populations.
And it goes way beyond just treating illness, right?
Absolutely. It's fundamentally about preventing illness, promoting healthy behaviors across the board, and this is key, tackling those underlying social, economic, and environmental factors that have such a huge impact on health.
Like housing, education, income.
Exactly. It's about creating conditions where entire communities can be healthier. Organizations like the WHO really stress how crucial this population health approach is for making healthcare systems sustainable long term.
Okay, so when we look at population health, what are the main things we're measuring or working on? What are the key components?
There are several core components. Obviously, the health outcomes themselves, things like life expectancy, rates of chronic disease, infant mortality, quality of life measures.
The ultimate results.
Right. Then there's promoting healthier lifestyles, nutrition, exercise, smoking cessation programs, substance abuse prevention, big focus area.
Getting people to adopt healthier habits.
Yep. Collaboration is another huge piece. We mentioned it before. Healthcare, public health, schools, employers, community groups, all working together. Can't do it alone.
Breaking down silos again.
Exactly. We also track health status indicators, things like obesity rates, vaccination coverage, mental health prevalence. These give us a snapshot of the population's current health.
The vital signs of the community, almost.
Kind of, yeah. And finally, those social determinants of health. Access to good food, safe housing, quality education, stable income, safe environments. Addressing these is fundamental to improving population health and reducing inequities.
Really is a holistic view. So just like with transitions, what are the exciting advances here? How is population health evolving?
Well, big data and analytics are revolutionizing things here too. Being able to analyze huge data sets lets us spot trends, identify high-risk groups, and tailor interventions much more effectively.
Got an example.
Yeah, think about using data to pinpoint neighborhoods with high rates of diabetes complications, then deploying targeted education, screening, and support programs right there. Studies show this approach can significantly reduce prevalence or complications, like maybe a 10% reduction in some targeted programs.
Using data to be smarter about where to focus efforts. What else?
Precision public health is another exciting area.
Precision, like personalized medicine, but for populations.
Kind of. It uses more granular data, maybe genomic data, environmental exposure data, detailed demographic info to design even more targeted prevention strategies for specific subgroups. A CDC trial, for instance, used this to boost cancer screening rates by about 15% in specific groups.
Wow, getting really specific with public health. And what about tackling those social determinants?
Community-based interventions are getting much more sophisticated and recognized. Programs designed with the community, often led by community members, to address local needs like food deserts, lack of safe places to exercise, or transportation barriers. Reports show these partnerships are key to improving health equity, maybe showing a 20% improvement in some metrics.
So grassroots efforts combined with data and system-level thinking. Are there big national initiatives driving this?
Yeah, several key ones. Healthy People 2030 in the U.S. sets national health objectives for the decade. It provides targets and tracks progress on hundreds of indicators.
Like a national health improvement plan.
Pretty much. And it's showing progress, things like increased vaccination rates, some reduction in opioid overdoses, meeting certain targets. Then there's the triple aim.
We hear that a lot. Remind us.
It's that framework. Simultaneously improve population health, enhance patient experience, and reduce per capita costs. It's a guiding star for many health systems. And evaluations show programs focused on the triple aim are bending the cost curve, maybe 15% reductions in some cases, while improving quality.
Experience, health, cost, a balancing act. What else?
Community Health Needs Assessments, or CHNAs. These are mandated for nonprofit hospitals by the ACA.
What do they involve?
Hospitals have to systematically assess the major health needs of the communities they serve and then develop strategies to address those needs. It forces them to look beyond their own walls. And CMS reports suggest these are leading to improvements like maybe 12% better access to care in some underserved areas because the CHNA identified the gap.
So using hospital resources to meet broader community needs. Now, this all sounds great, but it must be hard to implement. What are the big challenges?
Oh, definitely challenges. Data integration is a huge one. Getting data from clinics, hospitals, public health, social services, all into one place where you can actually analyze it. Tough. Different systems, privacy
The
concerns.
interoperability problem again?
Yep. Efforts on national data standards and health information exchanges are trying to tackle this, but it's slow going. Funding is another perennial issue.
These programs cost money.
They do. Prevention and community work often require upfront investment for long-term payoff, which can be hard to secure. Public-private partnerships are often crucial here to pool resources.
And the biggest challenge, maybe,
Health inequities. Huge disparities persist between different groups based on race, income, geography. Population health aims to reduce these, but it requires really intentional effort. Culturally competent interventions, addressing bias, advocating for policies that promote equity, it's complex and requires systemic change.
data, money, equity, major hurdles. Can you give us a concrete example of a population health initiative in action? Make it real.
Sure. Think about the CDC's work on hypertension, high blood pressure, especially in underserved communities.
Okay, what do they do?
It was multi-pronged. They supported things like mobile health clinics going into neighborhoods, telehealth for monitoring blood pressure remotely, partnering with pharmacies for medication management, patient education programs.
So meeting people where they are.
Exactly. And the results, measurable improvements,
Yeah.
maybe a 10% average reduction in blood pressure in the target group, significantly increased medication adherence, like 25% higher. That's population health making a tangible difference.
That really brings it to life.
Mm.
Okay, as we wrap up this deep dive, what's the main takeaway? If someone remembers only one thing about population health and care transitions.
I'd say it's that they are two sides of the same coin for better healthcare. You need smooth, safe care transitions for individual well-being, and you need that broader population health focus on prevention and addressing root causes to improve health for everyone and make the system sustainable. They're inseparable, really.
And we've seen that progress relies heavily on evidence, collaboration, and smart use of innovation, especially technology and data. Those stats on readmissions, communication errors, the impact of EHRs and specific models, they really drive home the potential.
Absolutely. And the solutions are getting more sophisticated, standardized protocols, AI, precision public health, community partnerships. There's a lot of positive momentum, even with the challenges.
So a final thought for everyone listening. Reflect on your own experiences or those of people you know with the healthcare system. Where have you seen transitions work well or maybe not so well? And stepping back, how could your own community become a healthier place? What role could you or local groups play?
Yeah, and consider how technology and data are changing everything. How we understand health, how we deliver care, both for individuals and whole populations. It's a field that's constantly moving.
It definitely is. The potential for improving quality, access, and equity is huge, and it's exciting to see these fields evolve.